Good afternoon, and welcome to our Crucial Conversations webinar today. It is being co-sponsored by the CDPH Immunization Branch and California Immunization Coalition. Today, our topic is effective communication without confrontation. The emojis are already starting to fly. We've had a huge response to this. I think it's just a great time for this conversation. It's always a good time for having better communication skills, but let's face it, now's a good time. I am Diane Evans. I always forget to introduce myself first. I'm Diane Evans. I will be your host. I work with CDPH. And next slide, please. So a little logistics today. We would love to have you ask questions as they come up. So go into that Q&A icon, and that is where you'll put your questions. We do have a CDPH panelist behind the scenes and a subject matter expert that can respond to some of those as we go through the webinar. And then any that we think would be really good for a discussion later on, we'll bring those up. So make sure that's where you put those questions. And as far as the chat goes, that's where we will drop links that come up from our presentation today. Like the first one is already there, which is where you'll be able to find the slide deck for today. Next slide, please. So just a reminder, this session is being recorded, and as you can see, we've already shared that link with you where you can find those slides. The recording will also be there once it's finished, and we have that ready for you. That's on the IZ Provider Webinars page on EasyIZ. If you'd like to be added to the CDPH email messaging listserv, then make sure you send your request to blanca.corona@cdph.ca.gov. And if you have post-webinar related questions, email me at diane.evans@cdph.ca.gov. Next slide, please. Our agenda today looks short, but it has, so much good information. I'm doing your welcome right now, and then Dr. Ken Hempstead will talk to you about effective communication without confrontation. And then our lovely Tricia Gamboa will review resources, because I always love for you to leave with lots of good resources that you can have going forward to use. And then we'll come together again at the end and have time for discussion, questions, answers. And don't forget to put those in the Q&A as we go. And then at the end, we can bring some of those back up and talk about them together. And then I'll wrap up, and you get to go on with your day with so much more information than you came in with. All right, next slide, please. All right, we have a poll today. And we do these polls with our Crucial Conversations webinars because we really do appreciate your feedback. And we want to make sure that we are choosing topics that are relevant and that are helpful. So at this point in time for you, what we would like to know is, how confident are you in your ability to speak effectively with patients about immunizations without confrontation? And as we launch that poll, you'll see everything from very confident down to not confident at all. And we'd love to have your feedback on this because, like I said, it really helps guide us as we plan these webinars going forward. So, I see the responses rolling in. Thank you. I appreciate that very much. And we'll leave that up for a little while and let you put in your responses. All right, next slide, please. And with no further ado, I would like to introduce Dr. Ken Hempstead. He is a primary care pediatrician at Kaiser Permanente Northern California. And in addition to his clinical duties, Dr. Hempstead serves as a communications consultant to other KP physicians. He provides training and coaching in various communication techniques and is renowned for his expert in vaccine communication. He has traveled nationally to educate audiences on having more effective and pleasant conversations about vaccines. And who doesn't need to know more about that? So without further ado, Dr. Hempstead, I will turn it over to you, and we can't wait to hear what you have to say.
Well, thank you so much, Diane. What a wonderful opportunity. I'm just absolutely thrilled. We both are so thrilled to see how many people have registered. And yeah, I can't imagine why there's some increased attention and focus on this area lately. Again, always a good time, as Diane said, but I think that this is really near and dear to our hearts right now. So I'm really looking forward to the opportunity and really appreciate you taking time out of your busy days to join me. I guarantee you'll get something out of it. So stick with us. Let's go ahead and advance the slide. I don't have anything to disclose, so that's easy. You can go to the next slide. So what we're looking at in terms of trying to have some changes in our practice, as the slide, at least on my end, is begrudgingly changing. You can go ahead and advance the animation so that comes on up for all of those bullet points there, please, Charles. So changes in practice are goals for today. We want to have an increased understanding of the role of communication in delivering messages about immunization. We want to understand some differences in parental attitudes along the vaccine hesitancy spectrum, or as I like to call it, the vaccine confidence spectrum, to put it a little more positively. And we're going to learn four very specific, wonderful tools of persuasion that you can apply to vaccine communication, or frankly, a lot of different conversations that you have professionally, even personally. So any kind of emotive conversation, you can use these skills for, and even use them with your teenagers. And you can ultimately feel more comfortable and effective when addressing immunizations with vaccine hesitant parents. So we really find, again, that's part of why that poll was there. It's not just about the confidence, it's about the comfort. These can be difficult conversations. They can be a source of what we call learned helplessness, right? That people just kind of get frustrated and give up, and just don't want to take the time anymore, and just don't feel like it's worth it. And so we're really going to give you some takeaways today of how to do this in a way that leaves you and the people that you're working with both much more satisfied. Next slide, please. So what's changed? So this is a, we'll get to in a moment, but this program was developed at Northern California Kaiser about 12 years ago now. And the great news is that the concepts are absolutely more important than ever. And so for some people on the call, you might have heard me talk before, and this will be a bit of a good refresher. And for others, this will be brand new information. But this is something that we, a team came up with about a dozen years ago. And so, yeah, some things have changed, right? COVID being probably the most prominent of them. And so we can all, with some warmth in our hearts, remember the time in the beginning of the pandemic where, even though things were scary, we were healthcare heroes, right? We enjoyed a relatively brief amount of time where public support was, certainly steadfast in our favor, and people like this boy here were willing to participate in doing what we could, the best we could under very difficult circumstances, to try to understand and control the pandemic. And ultimately, of course, though, we had some other effects of that, and some tides that got shifted, and ultimately produced some backlash to what those policies were, right? Everyone's familiar with that. So, but I think that's a big part of what we're trying to talk about, though, today, is not about beating ourselves up over that, but being realistic about what we are now dealing with in terms of kind of the after effect of all of this, politically and otherwise. Obviously now, what's happening at the federal level is to some degree reflective of a backlash. That there is obviously public sentiment that really does not feel that they were heard, and that things went well for them, and that they were empowered. Next slide, please. So again, it's not about beating anybody up. However, it's just being realistic about, well, what can we learn from our response, and what can we learn moving forward in terms of rebuilding connection, rebuilding trust? And that's what today is really all about ultimately. So I think if we're being honest with ourselves, if you can try for a moment to tie into some empathy. So to do that, I would imagine, I'm going to encourage you to imagine along with me, you are a former healthcare worker who was fired from their job for declining the COVID vaccine. Okay, just try, try to attach to that perspective, and empathize with it. And we have, that happened to thousands of healthcare workers. And, a huge chunk of the population didn't experience what we had wished for them to experience, that we really cared about what their situation was, and cared about them as humans, and wanted to save lives. However, if you embody that person's perspective, especially in retrospect, did they feel shamed, blamed, guilted, be the source of anger and vitriol even? or did they feel connection? Did, this, I'm proud of this slide on the right. That's from the Love Protects Us campaign, which, shameless plug, Kaiser was a sponsor of. And, if we can try to shift back to connection and move away from blame and shame, then I think that's our path here toward reconnecting with everybody that we want to understand public health and what we're all about here. So, I think it's a realistic way to look at what's happened. So next slide, please. So the question becomes, what do you know and what could we learn together today about how to effectively persuade? And that's going to depend a bit upon the context. So whether that's people who are just, refusing vaccines outright, or those that might just be delaying and have an alternate schedule, or the parents that are just unsure. So that's what we're here to discuss. Next slide, please. And you can advance the bullets on this one. Thank you, Charles. As I hinted at, this is a program that was developed by some pediatricians and some health educators about 12 years ago now. And at the time was really avant-garde. I mean, people had not, I don't think, been exposed to this sort of thinking about the communication tips and persuasion tips and where we're going wrong and where we could pivot into a better direction about how to provide a fresher approach to these difficult conversations. And a lot of where this lies is getting out of debate mode. So we're going to talk a bit about that. But I think that if we are being, again, just have some humility and are being honest with ourselves, it's almost as if there's, I always imagine like there's this little tiny, up in the corner of the room, this little tiny debate coach. And sometimes we fall into this debate mode where we're sort of scoring our little points in terms of winning from the debate coach's perspective, and absolutely losing in terms of the patient client public that we are trying to help understand our perspective. So we're really trying to avoid fruitless debate and maximize your persuasive ability here. Next slide, please. So can't be emphasized enough. Your goal is to persuade, not win the debate, right? So the win is, hey, I helped that person get their flu vaccine. That's awesome. That's my win. That's my only benchmark of success. Not, did I list off all of the different reasons why I'm right and you're wrong. That might make some part of my ego feel better, but totally ineffective and does not do this bridge to trust that we're talking about here. And that can be really hard. The public health, people, scientists that we want to be, have a really hard time not correcting mistaken ideas. It's what we call the correcting reflex. It is just built into our DNA at this point that, hey, I've got this information and I'm just going to share it with you. And so when the family says, oh, we don't take flu vaccine, it always makes us sick. That's that moment where you have to pause and recognize, I would love to correct you and explain to you why you're wrong. And I hope you can take away from today why that may not be effective and might actually make things worse. And so, pardon the pun here, but belief trumps science. Belief is stronger than proof, and as much as it pains us sometimes, as people that try to perform evidence-based medicine, belief will not be changed by evidence. So, as painful as those truths are, they are absolutely part of the core ideas here that I want you to take away. So, next slide, please. Just to continue to flesh out a big overview of the core concepts, it will come as no surprise to you, but just as a framework here today, that most parents who delay or refuse vaccines, they're not acting in isolation, right? I mean, it used to be family or school or church, neighborhood, and those were the influencers. And now, of course, we have just the onslaught of social media, YouTube, Google, Facebook, and any of you who have given a modicum of thought to the situation will recognize that these are, the algorithms are literally confirmation bias generators, right? I mean, that is like literally what they do. So, we have these silos and echo chambers and all this confirmation bias, and people just going down rabbit holes, and they will find countless people or bots and some combination to totally reinforce their beliefs. And so when you attack that, you're attacking their identity, which we'll talk more about. And really, it's very easy for them to just quickly polarize and quickly put you into that category of other. And they don't need to listen to the other. You're just one of those people. And you lose any ability to connect and build trust. So attacking their beliefs and or attacking the group's beliefs is fraught with difficulty. Next slide, please. So, I don't mean to sound too negative. I just want to drive home the points that a lot of what I would say our habitual traditional approach has some limitations. So we're talking a little bit about what not to do. Let's pivot a little bit into talking about what to do. So what we did is take advantage of an amazing, wonderful author and consultant. His name is Jay Heinrichs. I'll put a plug in for him. He wrote a book called Thank You for Arguing, and that's in the bibliography at the end. Fantastic, fantastic read. And he is not specific to medicine in the vaccine realm at all, but he is an expert at communication and rhetoric and persuasion. And basically, we were able to take these very, very old, tried and true rhetorical devices and figure out a way to apply them specifically to the vaccine conversation. And again, you can apply them to all sorts of other areas of public health, or again, even your personal life if you'd like. So we're going to unpack each one, but the four are listed here: cognitive ease, natural assumption, appeal to identity, and advantageous terms. Go ahead and advance the slide. So cognitive ease. This is great news for you, I promise. So, the way I think of this is if my blood pressure is going up, I am doing something wrong. Because if my blood pressure is going up, whoever I'm talking to, their blood pressure is going up too. We're probably falling into a bit of debate mode. We were falling into, I just want to win. We're polarizing. So if you feel like you're getting a little defensive, that is absolutely your cue to take a pause and take a deep breath and recognize what you're doing. You don't have to beat yourself up, but being mindful enough to recognize, okay, am I really maintaining cognitive ease here? So what this is about is the soft approach, the soft sell. This is not about bullying. This is not about the hard salesman approach. It is the absolute opposite. So when any of us are in a more relaxed state, we don't have to defend as hard. We don't have to just sort of wait for the gap in the conversation and just immediately provide our retort. We can actually maintain a listening, open attitude. So again, this is good for the patients. This is good for us. Always maintain this tone. Next slide. The next is called natural assumption. And if you're familiar with some of the vaccine communication literature, you might also see essentially the same concept, just being labeled differently as the announcement approach or the presumptive approach. But here we're going to call it natural assumption. And this is a very, very powerful, yet I would say nuanced technique that, again, we have to be mindful and careful of how we're applying it and not be manipulative. However, what we know, and we'll see from the literature in a few minutes, is this is really our most evidence-based tool here. So the importance of how we present our clear and confident recommendation is what absolutely wins the day. So even though we get, sometimes a little bit of our own reluctance to feel like, oh my gosh, I mean, this person is hesitant and, I'm going to then sort of approach it in a hesitant way, we can accidentally portray that we don't have our own strong convictions about what's, the right choice here. So approaching vaccination as the default option becomes the modus operandi here. So let's go ahead and order the shots before we start the exam, right? That's the presumptive approach. So we expect, just like checking the vision and checking the blood pressure, this is part of our standard care. This is part of my clear, confident recommendation of what I suggest for you today. Now, of course, if there are questions, if there's hesitancy, we're going to pivot and address that. But in terms of how we present the option, it's important to be clear and confident. So in other words, yes, we kind of then end up having them equate inaction with going with the flow, which is ultimately what they are here for. That's what they pay us for, is to be able to give our clear, confident recommendation. Next slide, please. And if you want to geek out on this is just, I'll quickly just say this. This uses what's called the risk fallacy phenomena. So when people are kind of faced with what they think might be a difficult decision, they will tend to go with inaction. And usually, if we don't set it up this way, the problem is inaction, of course, just easily blends with, no, we're not going to get that flu vaccine. And so if you present it as really the default option, then again, we're not trying to be manipulative in any way or bully in any way. I want to be crystal clear on that point. However, when we set somewhat of a reasonable expectation of what we suggest to happen, then yeah, they need to make an active choice to leave their child unprotected. And we're going to see some videos later with some nice examples of how to do that. So next slide, please. The third tool is what we call identity strategy. And I hinted at this before in the presentation. There's a couple of different ways that we harness and direct the energy of identity because it's huge. So the first way that we do that is really what we call appeal to self-image. So we want to call out, amplify, exemplify, emphasize, be purposeful about these are great parents. And I just, we all need to sometimes reground ourselves in that knowledge. None of these parents are waking up in the morning making a decision not to vaccinate because they want to annoy you, right? I mean, that's preposterous. Every parent is doing what you and I do. They're waking up, trying to make the best decision they can for their child. And just because they happen to have a different set of resources and information than we are relying upon doesn't make them bad parents. So we really have to remember that and be really, really cautious about some of the judgments that we're making. And so part of doing that, and frankly, a lot of patients and families at this point are expecting that. That has been the pattern, like we talked about before. And so you really would be well served to go out of your way to call that out, right? So not just think it, say it. Yeah, we'll see some examples in a minute. Good parents ask good questions. I can see you really care about this. I can see you've really been giving this some thought. I can see that this really is a difficult decision for you or a difficult conversation for you. I appreciate that you're able to have it with me, right? So we're trying to, you've gotten the best car seat, you're eating all organic, you're taking a leave from work to be home with your baby. You've done everything you can to protect little Sarah. And this is another layer of protection that I want you to have that my other patients enjoy. Next slide, please. The next way that we talk about identity strategy is talking about group identity. Sorry, next slide, Charles. Thank you. And we talk about groupthink and again, echo chambers, all that sort of thing. So hearkening back to that for a moment, understand what you're up against, so to speak. If all of their other sources of information and influence are telling them that, beware the COVID vaccine that's going to, do X, Y, and Z, if you just marginalize that and kind of figuratively or literally roll your eyes and kind of dismiss their group, good luck because they're going to do the same to you. They're just going to be like, oh, you are, I'm going to purposely stereotype here. You're just a sheeple, liberal, progressive, whatever, you can just imagine. And the point is, they're just going to polarize you and say, you are other than me. I don't need to be listening to this. I know my camp. You're clearly not in it. I don't really have anything to discuss here. As opposed to, hey, what we both want, super powerful phrasing, what we both want is to make the safest decision for Sarah. What we both care about is that Sarah has the safest winter possible, right? All that matters is what's happening in this room. Let's not worry about all the noise outside of it. All that sort of thing is very, very powerful. And again, it may not do it that much in that one interaction. However, over our long haul, I mean, I don't know how many years it's going to take us to help rebuild some of the public trust that's been lost, but this is the path toward that. Next slide, please. The last of the four tools, and you can just pull down the rest of the animation for this slide too. Advantageous terms, words matter, and sorry, grown, but think of politicians, and they like to repeat themselves, right? So just use that as your teaching point to remember this tool. So yes, repetition works. Repetition leads to belief. So specifically using positive terms. So you saw me doing it just a moment ago about, protection, health, safest. Those are the things that actually stick in our heads. And I think along a similar vein, again, sorry, but like a politician, they try to get back to their talking points as soon as they can because it works. And I kind of think of it as a pretty decent analogy to the vaccine discussion, where of course I'm going to give you an answer to any question you're going to have. And I'm going to be aware to not fall into debate mode. And I'm going to kind of try to get back to the why as quickly as I can. So going back to our flu example, oh no, we don't take the flu vaccine, it makes us sick every year. Well, rather than going through my correcting reflex of correcting that idea, I could just simply pivot and say, I hear what you're saying. Pause. My experience is that this is a really, really effective way to keep kids out of the clinic and out of the hospital. I just would hate to see that happen to Sarah if we could have prevented that, right? So I don't have to necessarily, again, take that bait. I can just focus on the why and use the advantageous terms. Okay, next slide. So pivoting, let's just talk a little bit more about some other elements of vaccine confidence. So it's certainly not a one-size-fits-all approach. The groups, of course, and their perspectives are quite diverse, and so their different reasonings and framings for hesitancy similarly are diverse. And I think, talk about what's changed from 12 years ago. I think if we're being humble and honest, we did not have nearly the frame that was adequately focused on disenfranchised communities and communities of color. And I think it's worth pointing out in this presentation today that, not to negatively stereotype, but to try to be helpful, we do recognize that communities of color are more hesitant on average. And, we need to be mindful of that. And within those groups, of course, each has their own individual reasoning. However, you can still use these generalizations to apply to pretty much any situation you can imagine. So next slide, please. If we're being honest, as I hinted at before, we tend to fall into some judgment. All right. We may think we're really good actors, but it comes across, even if it's truly subconsciously. So, I think putting a little check on our judgment and our blame and our shame would really behoove us. And at a bare minimum, the bottom, half of this graphic of certainly falling into the old habit of using facts or studies, guidelines, CDC recommendations. I know, I get it, painful. It's our bread and butter, and it's not terribly persuasive. So just understand the limitations of that approach. It has its place. We have to educate the public for sure. But oftentimes, especially when we're talking about an individual conversation, it's not news to anyone that doctors recommend vaccines. That's not, they don't need to be educated that that's the case, right? They have absorbed that information and chosen to reject it. So using more facts and figures usually not terribly helpful. Next slide, please. So it begs the question though, do facts matter? And the way that I would try to help frame that is, as written here, thinking about the more vaccine confident the person is, the more they actually are asking you for scientific answers rather than you just, providing them, the more likely it is that factual information will actually be helpful. Again, though, don't fall into debate mode. So we love the phrasing, don't debate, just relate. Realize the limitations of correcting your mistaken ideas and, really anchoring back to empathy and alignment. And so those are much more likely to help than facts. As I said, most people are well aware our stance on vaccines. However, next slide, please. Misinformation, as you know, I mean, we could have spent the whole hour just on this topic, and you can still apply everything that I'm going to teach you today to social media, by the way. But yeah, let's be real. Misinformation is huge. Some of it I would call is more innocent, but a lot of it, as many of you are probably familiar with, is really a very organized approach and a very well-funded approach. And again, it stinks, but I kind of cringe when families say, well, we're going to do our own research. I'm sure you've all heard that many, many, many times. And that is such a tough one because the reality is you can't. I mean, I would just totally stand by that statement. That is not a thing. So just doing online searches is not doing research, and it's just not realistic to think that our average citizen can go out and properly evaluate the literature. That's just not in their skill set any more than I should not be speaking about the safety of nuclear power plants, right? Like it's just not something I'm a subject matter expert at. So even though people have opinions about nuclear power safety, I would argue they probably shouldn't because that's not really what they know. And the same thing here. It's just really, really tough. So we love that people want to have that empowerment. Like that's awesome. We want a population that is empowered and actually cares enough to do the research. That's amazing. It's just really, really, really hard to implement that. So we have to do what we can to work in that context. Next slide, please. So we're back to connection, empathy, and alignment. So yes, be prepared to give a short, clear answer to direct questions, but understand the limitations of that to actually help persuade people. Understanding that, especially with the long game in mind, this is much more about trust and rebuilding trust than it is about facts. Next slide, please. So other ways to try to help tie into sources of empathy for us is we are all doing the exact same thing that the rest of the public is. In other words, uh, society has become far too technologically advanced, which just gets more by the day. So this is only going to be more of a problem as we all live through life. So the more technologically advanced a society gets, the more separated any of us are from primary understanding of things, right? So, in other words, we all have to use shortcuts. We all have to use trusted sources of information. You're listening to me today to get information, right? You're trusting that it's accurate. And I might listen to the CDC or the CDPH or the AAP, right? And so we all are doing these shortcuts. So try to empathize with that and understand that for any of us, then, if we're being humble and honest, both facts and fallacies both get examined through our own individual filters and can get very difficult to distinguish. Ultimately, we, like everyone, kind of relies on trust more than a primary understanding of the science. So, yes, we all have our silos. We all have problematic confirmation bias. So, we can help to empathize with where that family might be coming from. And so, we also see things as we want them to fit into that pre existing narrative. And we all put our faith in certain institutions. So, being able to tie into that empathy is going to be hugely important and really change the tone and tenor of how you approach these families and these conversations. So, next slide, please. And again, in terms of empathy and building on this, we need to talk about mistrust. And again, we could easily spend the hour on this. I know that you're all very familiar with this. However, it's just worth pointing out that, of course, different groups have different, very understandable reasons for mistrust, whether that's the government, the establishment, political parties, whatever it is. And that, again, particularly for communities of color, we have hopefully learned a lot, and especially the last 5 years, of understanding what those sources are of mistrust, not just from a historical perspective, but from a current one as well. So again, it's not all bad news. The good news is that if we can regain that trust using empathy and alignment, it really shouldn't matter exactly where all those sources came from. We're still trying to apply the same tools here. Next slide, please. So I hate apologizing for slides, but I'm going to apologize for this slide. We're going to break this down more in a few minutes. And so this is not about memorizing an algorithm or anything like that, just to be clear, but it's just to have a little bit for the more visual learners out there of what kind of this vaccine confidence spectrum kind of looks like, and just be a bit of a reminder so that as you are approaching these conversations, you can kind of bucket people, if you will, and then recognize, okay, I do need to alter my approach according to what bucket that person's in. And some of that is fairly intuitive, of course, but I want us to be a little bit more purposeful, a little more mindful and thoughtful of how we are doing that. And so we're going to kind of break down each one of these groups in just a few minutes here, but this is kind of just trying to put it all together in terms of what the vaccine hesitancy or confidence spectrum looks like and how that might change our approach. But we'll get to each one in a moment. So next slide, please. Before we do that, again, we are ultimately, geeking out on this stuff. So I don't want to go to the literature. Next slide, please. Some of this stuff was just really wonderful that it came out right after we created this program. So it felt very validating to see this stuff in the literature right after we created the program about, again, 12 years ago. So this is a great study. This one, I'll just go through it quickly. They basically just videotaped, clinic interactions in the exam room, and then, retroactively just watched the videotape and just graded them. And they were specifically looking for whether there was that presumptive approach, time to do the shots now, versus that participatory approach. Well, what would you like to do about the vaccines? Next slide, please. So that's what, again, we're terming natural assumption here. And so this is kind of nuts. I mean, I don't know the last time you saw an odds ratio of 17.5, but pardon me, I'm going to take a drink of water, too much talking. But, that's kind of bonkers. So they found that looking again in retrospect, it's not a randomized trial. I mean, that would be really bonkers if that was the odds ratio of a randomized trial. But just looking retrospectively at these videotapes, they found the use of that presumptive approach was far more effective. And then furthermore, another nice little pearl that they took from that is when parents had shown some initial reluctance or resistance, about half of the providers they found ended up coming back to their pursuit of their original recommendation. And about half of the time, the family changed their mind. So that's another huge takeaway is sort of, yeah, start with a clear, confident recommendation, start with natural assumption if it's at all reasonable to do so, and don't give up on it. Come on back to it at the end. You might be surprised how many people you did change their mind and figured you didn't. So don't give up even within the context of a single visit. Next slide, please. This one came out about a year later. This was great. Brennan Nyhan is just awesome. He's just a real great social scientist in this space. So lots of great stuff about vaccines and politics. So super geeky if you want to look him up. This one was pretty big. I mean, over 1,700 parents were studied and asked about different things, including their intent to vaccinate with the MMR vaccine. So next slide, please. And so then they got randomized into 5 groups. There were 4 intervention groups and then 1 control group. So I want you to think about these different interventions as I illustrate them here. So CDC, so one group was given CDC information explaining the lack of evidence of a link between MMR and autism. One group was basically given the statement from the VIS about the dangers of the diseases that are prevented by the MMR vaccine. And one was given images of children who have had diseases prevented by the MMR vaccine. And then one was a dramatic narrative about an infant who almost died of measles from a CDC fact sheet. And yes, even though this slide is now 12 years old, of course, we're right back to measles again. Nothing really fully goes out of fashion, apparently. So I want you to think to yourself for a moment about which of these interventions was the most successful. What would you just intuitively guess of these interventions was the most successful? And we advance the slide, please. And some of you have heard this talk before, but none of the interventions increase the parental intent to vaccinate. And even worse, among parents with the least favorable vaccine attitudes, the information intervention further reduced vaccination intent compared to the pre-study survey. Further reduced. So I'm not making this up. You really are making things worse sometimes, I promise. And the dramatic narrative about measles and the images of sick children caused what's called a danger priming effect, which increased misperceptions about MMR. Next slide, please. So things really can backfire. It's not just a neutral, you wasted your time. So this finding suggests that respondents brought to mind other concerns about vaccines to defend their anti-vaccine attitudes, which hopefully at this point in the talk is no longer a surprise. So, and again, Mr. Nyhan explains that's a response that is broadly consistent with the literature on motivated reasoning about both politics and vaccines. So, like it or not, the best response to false beliefs is not necessarily providing correct information. Likewise, trying to scare parents with emotive stories could paradoxically increase vaccine safety concerns, especially among those who are already hesitant to immunize. So again, pardon the pun, but belief trumps facts. So debating with scientific facts can be seen as an attack on the hesitant parent's identity and can backfire. Next slide, please. So I think you get the idea. I won't belabor the point. So let's break down the different hesitancy groups as promised. Next slide, please. So we've got the unsure parent. I always think of this as first-time parent, 2-month visit, coming in. Everyone told them at the baby shower, don't let them vaccinate your kid, or don't let them do all of them at once, right? And they just don't know. They're not totally in a camp. All they know is what someone told them at the baby shower. So unsure parent, they're relatively persuadable. They still have some trust. They don't have unshakable beliefs. So yes, they're a little bit more open to more of a factual argument, so to speak. Next slide. So again, don't fuss over the algorithm itself, but yeah, we're going to start with natural assumption. Of course, you use the other tools, appeal to identity. We can address specific concerns. We might use a mild emotional appeal, like, hey, I want to make sure we don't leave Sarah unprotected, and then help them to kind of frame the choice again, essentially using natural assumption. Next slide. So some time ago, we created these videos. This was kind of in the context of AB 2109, which the veterans here will remember was, they had to get the sign off from the healthcare provider to validate their vaccine exemption for school. So you'll see some of that context later, but, just kind of a fun way to illustrate the point. It's hard to make a non-cheesy video, I would argue, but, I think we did a decent job. So go ahead and advance the slide and play the first scenario, please.
Charles, we're not hearing the sound on this one.
The setting is Dr. Patterson's office in Hayward, California. Mr. and Mrs. Smith bring their first baby, Isabel, for her 2-month appointment. They look very nervous. Note that the doctor makes eye contact to establish a relationship. She's aiming to put the parents at ease.
Well, hi guys, how are you? Look at Isabel, she looks great. She's so alert and getting so much bigger. How you guys been?
Dr. Patterson, we are so happy with Isabel. She's so amazing. I could watch her all day long.
She looks great. Let me take a minute and order your shots before we get started so that you don't have to wait afterwards.
Note that Dr. Patterson is using the natural assumption technique.
Dr. Patterson, we're not really sure about getting Isabel vaccinated.
Well, of course, you're good parents. It's natural and important to have questions. I had tons of questions when my kids were young. So what's on your mind?
Note that Dr. Patterson is using the appeal to identity technique in 2 ways. She's appealing to the parents' identity as good parents. She's also establishing a common identity with them as protectors of baby Isabel.
Well, I've heard that the vaccines can have some really bad side effects. I mean, we don't want to hurt her. What do you think?
Well, they can cause very minor side effects like a bit of fussiness or low fever for a day. Serious side effects are extremely rare. Vaccines work by making the body think it's coming down with the disease, and when fever or soreness happen, it's because her body is setting up its defenses. And then if the real disease comes by, her body's ready with its defenses. And any fever or soreness is easy to treat, and it won't last long. Again, as far as bad side effects, I can't remember the last time I saw one. And we give shots to thousands of babies here every year.
The doctor has chosen to address their concern directly because the parents are open to discussion.
Well, how many shots would we have to give her today?
Well, our normal course is to give Isabel 3 shots as well as 1 vaccine by mouth. By the time you leave today, she'll have forgotten all about it, and we'll all know that she'll be better protected against these diseases.
Can't we just wait a few more months until she's stronger?
Her body is strong enough to handle the protection the shots will give her. It's the disease she's too little to fight on her own. Let's go ahead and get Isabel protected today with the normal course of vaccines.
Note that Dr. Patterson has used a number of techniques here, including repeating the word protection and revisiting the natural assumption technique.
Okay. All right, let me take a minute and order the shots, and then I want to take a look at Isabel.
And so, Dr. Patterson has responded successfully to the Smiths' concerns, and Isabel gets her vaccines. Remember, when discussing specific vaccines, doctors should counsel parents regarding the risks and benefits and provide the vaccine information statements as required.
Thank you, Charles. Good job. You can advance the slide again. All right, and we've got, I think another video, so you can advance one more time and play that one, please.
The setting is Dr. Clark's office in Petaluma, California. Randy and Paula Wexler bring their baby, Julia, to her 2-month visit. Julia is their first child, and they're pretty nervous. The doctor has smiled and made eye contact to put the parents at ease.
Wow, Julia is so big and so alert. How have you two been?
Actually, we're really worried about her, Dr. Clark. She's been fussy a lot, and we're not getting much sleep.
And it's so tough when you can't sleep. It's normal to worry about your baby. You're good parents. I'll bet we can find ways to lessen her fussiness so you'll be on the path to a good night's sleep. Before we get started, let me take a minute and order her shots now so that you won't have to wait very long at the end of our visit.
The doctor is using the natural assumption technique. He assumes that the baby will get the shots.
Dr. Clark, we actually have some questions about getting Julia vaccinated.
Of course. What's on your mind?
Some of the websites that we've been looking at say that vaccines aren't needed anymore.
Notice that Dr. Clark stays calm. He doesn't let any annoyance show. He maintains a caring, confident manner.
The shots have been so successful that most people haven't experienced the diseases themselves. The diseases are still out there, and unfortunately they prey on the young. I'm grateful that we have vaccines so that we can protect our children. We have to protect Julia because she's vulnerable.
I don't know. I've read that the shots have too many ingredients for a little baby's immune system. I mean, she's already so fussy.
It sounds like you're worried about the number of proteins in the shots. Julia's immune system is designed to multitask. She's already encountered thousands of everyday germs and handles them easily. Her body can handle much more than what is in the shots. And today's shots are actually far more refined than what we had as children.
I don't know. It just doesn't seem necessary at this point.
What we all want is to protect Julia from harm. I recall a few years ago I was called to the emergency room. We tried to save a baby who was very sick. She died of a disease that she would not have had if she had been immunized. These vaccines are more important now than ever. We all have her best interest at heart, and we need to protect her. Let's take a look at Julia now.
Note that Dr. Clark realized he was not going to succeed by addressing individual concerns, so he switched to 3 other strategies: an emotional appeal, an appeal to identity, and distraction. By refocusing the conversation, he gives the parents a few minutes to absorb what he has said about immunization. He also makes sure to talk with them about how to help Julia so that she can be more comfortable and less fussy.
Julia looks great. She's growing and developing nicely. All that's left now is her shots. Do you have any further thoughts before I order them?
Dr. Clark has returned to the natural assumption technique. Let's see what happens.
No, it's okay. Let's go ahead and do them.
That's great. I know you'll be so glad that you made the decision to protect Julia.
And so, that day, baby Julia is protected by vaccinations. Remember, when discussing specific vaccines, doctors should counsel parents regarding the risks and benefits and provide the vaccine information statements as required.
Thanks again, Charles. You can advance the slide. So I hope, it would be so awesome if we were all in person. We could, have role play and all sorts of great stuff. But, through the limitations of technology here, we're trying to do our best to at least give you a different way to learn these concepts. So I hope that that's helpful. I want to be mindful of time, so I'm going to kind of speed up a little bit here. That yes, the next sort of stage, the delaying parent. Yeah, obviously there's some resistance to our prior, probably more traditional logical approaches. You usually have a pretty strong belief system attached to a group, but ultimately we can be helpful here. Next slide. So again, identity is what it's all about, not debating and not alienating the parents. Next slide. Keep going with the animation. Yep. Again, we've emphasized this. If we attack those beliefs, we're going to alienate and lose your persuasive ability just because we're going to get polarized. Keep going. And again, that's kind of just illustrated here on the algorithm. Let's go to the next slide. Great. And next slide, we can play that one.
The setting is Dr. Foster's office in Davis, California. Mr. Daniels has brought his son, Eli, in for his 12-month appointment. So far, Eli has had 1 DTaP shot, 1 hip shot, but no other vaccinations. Dr. Foster is prepared for today's visit. She's aware of the parents' concerns about vaccinations. She knows she was unsuccessful persuading the parents to fully vaccinate. They didn't seem to be impressed by her scientific arguments. Today, she's going to try some new techniques to try to convince them.
Good morning.
Hi, Dr. Foster.
Wow, Eli's gotten so big. It's been a long time since I've seen you. How's everything going?
Everything's going great. Eli just had his first birthday party. He loved his cake.
I'll bet. Wow, it's hard to believe that a year has passed already. So today we're going to see how Eli is growing and developing. Before we get started, let's order the vaccines he needs so they'll be ready when we finish our visit.
Dr. Foster is engaging Mr. Daniels to make him comfortable and receptive. She wants to put him in a state of cognitive ease. She uses the natural assumption technique, presenting vaccination as the default option.
We want to keep spacing out the shots. I've been doing a lot of research, and I think we're giving way too many vaccines to our kids.
You're a dedicated parent to take the time to do the research. When my kids were little, I felt so protective of them. I can see you feel the same way. What we have in common is we both want what's best for Eli, to keep him healthy and safe. I feel protective of Eli too. With so much conflicting information out there, sometimes I think it's hard for a conscientious parent like you to decide what to do. We can work together to find the right approach to protect your son.
Dr. Foster is using the identity strategy in 2 ways. She's acknowledging Mr. Daniels' efforts to be a good parent, and she's expressing her common concern for the baby. She's also avoiding a debate about the validity of the parent's research, since she knows that belief is stronger than scientific proof.
Knowing what to do can be stressful. You try to be a good parent.
Right. It's really hard work. Let's go ahead and talk about protecting Eli against some of those diseases that can prey on kids his age. Then we can easily catch him up to the normal schedule for protection that my other patients have.
Dr. Foster is now using advantageous words like protection. Additionally, she's repeating the use of the natural assumption technique.
Okay, but I don't want to do everything all at once.
That's your choice. But in the meantime, you need to be aware that there will be a protection gap for Eli. You'll need to worry about him catching one of those diseases until he gets the protection. Let's do a few today and have him come back in a few weeks and get some more. I think we'll both feel better once we get Eli protected.
Well, I'm okay with a few shots today, just not too many.
Very good. Let's see what vaccinations Eli is scheduled for today.
And so, Dr. Foster has successfully forged a common identity with Mr. Daniels. Doctor and parent are both protectors of Eli. As a result, she's making some progress towards getting Eli on a normal vaccination schedule. Remember, when discussing specific vaccines, doctors should counsel parents regarding the risks and benefits and provide the vaccine information statements as required.
All right, Charles, keep advancing, please. All right, we're in the home stretch here. Refusing parents. So again, these are very, very important conversations where we need to have realistic goals. So we're not talking about trying to magically, flip a person's entire, belief system, but we absolutely have an opportunity to strengthen our bond with the patients or their families versus further sour and create more seeds of mistrust. So next slide, please. And that's just illustrated here on this graphic. So again, don't debate, just relate. Try to establish whatever common ground you have. Yes, you make it clear what your stance is. You've given your clear, confident recommendation. You're not going to shy away from that, but you can do it in a way that really does reinforce your bond with the family. Next slide, and we can play the video.
The setting is the office of Dr. Sandra Keith in Roseville, California. Dr. Keith is meeting with Mr. and Mrs. Jones and their son, Andrew. Andrew is 5 and has never received any vaccines, despite Dr. Keith's best efforts to persuade them to do so.
Hi, Andrew. Mr. and Mrs. Jones, it's good to see you. How are you?
Hi. We need you to sign the new school form for the shots.
I'd be happy to take care of this for you today.
Dr. Keith has made a strategic choice by agreeing immediately to sign the form. She senses that Mr. Jones is worried that she might refuse to sign it. She knows that when people are comfortable, they're more open to hearing differing opinions. So she has acted quickly to alleviate Mr. Jones's concern and to put both parents at ease. Her approach is called the cognitive ease technique.
I know how you feel about vaccinations. It must be tough for you to be here.
It is, Dr. Keith. The government is obviously trying to force us to get immunized.
And we're not going along with that.
Dr. Keith is focused on listening to the parents. She's careful not to show any frustration, and she's very careful not to interrupt. Her approach is to create listening, a state where both she and the parents are willing to listen to each other.
Understood. It must be tough for you to be here. It's nice to see you, though. Andrew's getting so big. People must look at him and think he's in the 2nd grade. How's he liking kindergarten?
He loves his new school. And he's made new friends, and as you can see, he's already reading.
I can see that. He's sitting there so quietly with that picture book. Say, while you're here, is there anything else I can do for you?
Well, he's been complaining of some pain in his ear.
Okay, well, let me have a look at it.
Dr. Keith is using 2 strategies. She knows that examining Andrew reminds the Joneses of the concern she shares with them for their child. This approach is called forging a common identity. This reinforces her bond with the family. She also temporarily changes the subject because she knows that distraction is sometimes useful in decreasing conflict in a discussion.
It looks okay. It looks like he may have had a cold recently because there's a little bit of fluid behind one of the eardrums, but it should go away on its own.
Great, thanks.
Let's take this opportunity to talk about protecting Andrew from some of the diseases that are in the community. You know there's an epidemic of whooping cough right now.
Dr. Keith, you know our concerns about immunizations.
Could you share them with me again?
Where to start? They're unnatural. They're unnecessary, and they're part of a conspiracy to sell medicine at a high cost.
Mrs. Jones, what are your concerns?
They're full of bad ingredients like mercury, and they cause all sorts of diseases like autism and who knows what else. Besides, none of Andrew's friends at school are vaccinated, and look how well they're all doing.
I can see that vaccinations really worry you, and I do admire that you're doing what you think is right. And you know, I worry about Andrew too. I'm worried about leaving him unprotected from diseases that can be very serious, even deadly. I've seen the effects of pertussis and pneumococcus disease on kids, and I never want to see anything bad like that happen to Andrew. These are serious diseases we're talking about. We've made amazing progress in protecting kids from them, and I want Andrew to have his fair chance at that.
Dr. Keith is using the most important approach that physicians can use with parents who are refusing. Don't debate, just relate. She listens to the Joneses and does not correct them, despite the temptation. She expresses her shared concern about Andrew, which again builds common ground with them. She also attempts to persuade them by using advantageous terms such as protecting him from serious diseases.
No. Dr. Keith, I know you mean well, but we're not going to give Andrew any shots.
No, we're not.
Okay. Please understand, though, that you have a special responsibility that comes with leaving Andrew unprotected. If he gets sick, you need to let us know right away. It will be important to tell any doctor you see that he's not immunized. When he does get sick, we'll have to consider more serious diseases than we normally do. Also, if you hear of any outbreaks around you, remember, Andrew may not have protection against those germs, so you'd want to get him vaccinated right away.
We're not shy about letting doctors know he's not vaccinated.
That's true.
And we'll keep an eye out for any outbreaks.
Are there any of these diseases you'd consider protecting Andrew against today?
No.
No.
Okay. It's been good to see you. Hey, Andrew, I have dinosaur stickers. What kind do you want?
And so Andrew Jones leaves without his vaccinations. However, the provider-parent relationship has been strengthened. Dr. Keith has successfully used the key technique, don't debate, just relate, leaving the door open for future discussions. Remember, when discussing specific vaccines, doctors should counsel parents regarding the risks and benefits and provide the vaccine information statements as required.
Thanks, Charles. Let's advance the slide. And you can go all through the bullets of this. So just to quickly wrap us up and head into Q&A. So hopefully, again, you've come away with some good little pearls here of understanding limitations of the traditional approach that we all fall into, understand some of those differences of how we might approach different folks along the different stages of hesitancy, and understand these 4 tools of persuasion. Next slide, please. Yeah, challenge yourself to have fun with this. I just want to give credit. This was a group effort, so lots of great minds, went into the making of this. And next slide, please. Here's a bibliography for you, so you can capture a screenshot that and peruse that later if you would like. And next slide, please. So this is important. I know that it is a true privilege to get to present to this very wide and large audience today, and I do not want to in any way abuse that privilege. In other words, these are proprietary materials, so despite the fact that this is now recorded and the slides have been shared, they are proprietary information of Kaiser Permanente. So please, that you can use them for your own personal use, but anything beyond that requires permission. And so ultimately reach out to CDPH. You can reach out to me to work out any details of how you might have a request along those lines. So just need to include that so that we can have success with future permissions for future presentations such as this one. And I think that's my last slide. 102, did pretty good. All right, 2 minutes over.
That was some great information, Dr. Hempstead. Thank you. And now I'm going to quickly hand it over to Tricia. She's going to share some fabulous resources, and then we will have a few minutes at the end to ask some questions.
Thank you, Diane, and good afternoon, everyone. My name is Tricia Gamboa, and I'm a health educator with the immunization branch here at CDPH, and I'll be going over additional resources and tools to help you in your practice to improve patients' understanding and acceptance of vaccines to really go along with what Dr. Hempstead said. Next slide, please. So I'd like to start off by promoting our CDPH website for providers. That's easyiz.org. This slide shows our EasyIZ homepage and probably serves as a reminder for most of you. But for those who are not familiar, this is our main website where you can locate vaccine materials and resources. Next slide, please. On EasyIZ, we have 2 main web pages for providers that are used for education on vaccine safety. The first page on the left is our parent education page with guides and communication tools when talking to parents. There are general resources for guidance in communicating benefits of vaccines and addressing concerns parents may have. The second webpage on the right is our immunization studies and references page, which includes links to trusted sources that compile vaccine safety research, as well as citations for studies on key vaccine safety topics. This provides more of the scientific literature on vaccines for providers. We have it organized in several topics, from general safety to breastfeeding, pregnancy, and vaccines to ingredients in vaccines and more. So hope you find that helpful and check those pages out. Next slide, please. On to some additional provider resources outside of EasyIZ. I'll just run through these briefly. Immunize.org has a nicely organized way to review vaccine guidance based on topics of concern. So this is shown on the right-hand side. CDC and Children's Hospital of Philadelphia are great hubs of knowledge with further resources on how to talk to parents and increase vaccine confidence. Lastly, we've linked below a study on vaccine hesitancy, specifically in refugee, immigrant, and migrant populations here in the US. And this information may be helpful in serving those groups. So click on these links for more. Next slide, please. I'd like to share a resource from the Public Health Communications Collaborative, which is a learning and information hub for professionals who communicate about public health and provide relevant, timely, and practical communication tools and learning opportunities. Public Health Communications Collaborative published this guide for communicating more effectively about vaccines. And this is a great toolkit that has communication tips, vaccine messages that resonate better with the public, all based on focus group findings. And some examples are pictured below for messages that are actually found more effective among the public. You can find other helpful approaches on effective vaccine communication, webinars on this topic, and more resources on their website linked here. Next slide. So continuing with more resources for crafting effective communication, on this first bullet, Public Health Communications Collaborative also has a great tool for general public health messaging using plain language. And that's clear and easy to understand for the public, and that will help you in developing communications. CDC also has print and media resources for you to share with your patients to promote vaccines. And lastly, the Association of Immunization Managers has a great webinar series for increasing vaccine confidence. I've put 2 screenshots of their videos below, and these are really helpful as they go through examples of messages and their findings on what works and what doesn't work in communication about immunizations. So check all of those out for yourself and share it with your staff as well. Next slide. On to resources you can share directly with parents. The first bullet is our EZZ Parent Education Vaccine Safety webpage again. And as you can see though, on the bottom, the For Parent section has a list of handouts, websites, and videos to share with parents to address any hesitancy or to continue their education. So that's really helpful. And then also CDC links here about common concerns and concerns they have with vaccines. And then lastly, I really want to highlight healthychildren.org. It's a great resource shown on the bottom right with articles, guides, and there's even an online course parents can take on childhood immunizations. So please check those out and share those with your patients, parents, and with staff as well. Next slide. So on this slide, we're sharing vaccine education for pregnant patients. So immunization talks often begin before babies are born, as several immunizations are specifically recommended for pregnant patients. So working with parents to ease to alleviate their concerns, and it's very important during this time before their baby is born to also help them become more vaccine confident when it's time to immunize their baby. So these are really great take-home materials. They're comprehensive for all recommended prenatal vaccines. So the 2 on the left, free copies can be ordered using the link with the form that's linked there. And then the 1 on the right can be ordered through our local health departments, and that's linked for you as well. Also note that all of these are both in English and in Spanish. So we'll have the emojis for that as well. Next slide, please. Now I'd like to highlight our respiratory disease pages for providers on EZIZ, as respiratory viruses are still circulating, but also these pages have communication tools and promotional flyers for patients. And you can see, for example, on our COVID-19 vaccine resources page, we have a communicating with patients section, so you can get some guidance on how to communicate to patients and parents about these specific vaccines. Next slide. So lastly, I'd like to feature some CDPH toolkits found on our CDPH website. Our Office of Communications has updated these toolkits that contain messaging, images, and even some videos to help promote vaccines in your practice. Starting on the left, the first toolkit is for general respiratory prevention. The second toolkit is for routine immunizations during childhood and adolescence. And then highlighting our measles toolkit, as we've all heard of measles outbreaks happening in our country and around the world at this time. Vaccination is especially important as traveling increases, so please check that toolkit out. And the fourth and last toolkit is focused on RSV protection, providing promotion for immunization and other methods in preventing the spread of RSV, as it is still RSV season for infants and young children, and they can still be immunized till the end of this month. So for this and future seasons, please keep this toolkit in mind and check out all of our other communication toolkits on our CDPH website. And so this is my last slide, so we'll go ahead to the next one. And I'll pass it over to you, Diane. Thank you.
Thank you so much, Tricia. And now, that poll that you took way at the beginning, we have another one that looks exactly the same, actually. But now that you've had all of this information and all of these resources, let us know, how confident are you now in your ability to speak effectively with patients about immunizations without confrontation? Everywhere from very confident to not confident at all. So again, thank you so much for your participation. It really helps us to get this feedback at the beginning and the end. And now, next slide, please. As you answer that poll, we're going to go on to some Q&A. We had some great questions that popped up during the webinar, so I will share some of those. One came through email, and I'm going to start with that from Irene Landaw. When the curriculum was originally rolled out, there was no way to accurately measure its efficacy, since it was not concomitant with a sequence of 2 new California laws mandating vaccination for school entry. Since that time, the curriculum has been introduced in many other states over many years. Do we now have data on its efficacy in influencing immunization rates? Has the development and subsequent skepticism of the COVID vaccination changed the landscape? Woo, that's a big one.
So, hi, Irene. It's been a while. Thank you for your questions. So no is the short answer to your first question. I wish I could say that we had great data, and I know that is a super dissatisfying answer. What you'd really need to, I mean, part of what's difficult about that is you'd really need your control group, right? So, in a perfect world, you'd have a randomized controlled trial, and you'd have, these clinics doing it this way and the other clinics using their traditional approach. And then you could try to figure out how to minimize all the confounding variables. But yeah, we always, just as before, with the law changes, there's always confounding variables. So there are much bigger shifts that are impacting vaccine rates than any one given conversation or any one given program. So I wish I could say that there's this great bundle of evidence for this approach. And maybe someday that'll be the case, but I don't have that for you. I think the second part of your question is, how has the landscape changed? And if memory serves, you've been retired for a little bit of time, and it's changed a lot, and not in a favorable direction. That again, that's part of what we are talking about here, and why this is so important is, yes, I mean, there was a huge amount of mistrust generated, and people, of course, felt very bullied and manipulated. And we are suffering a lashing back from that, and so it's going to take quite some time to rebuild trust. So we see that in not just COVID, flu, RSV vaccine. We just see it in the whole array of vaccinations, the ones that had really no controversy at all attached to them. So it bleeds out, and just frankly, it bleeds out into other similar things. So lots and lots of vitamin K refusal, erythromycin ointment for newborn refusal, even newborn screen refusal. So you're seeing a real obvious shift in the landscape over the past few years as a consequence of this loss of trust that ideally, I hope that I'm trying to emphasize here, that there are some steps to rebuild, focusing on empathy, not being manipulative, not bullying, not being coercive, and aligning as best we can. So that's the goal. But yes, we're all feeling this every day.
Okay, thank you. Here's another good one and long. Donna asks, one of our main issues is with community providers who don't follow the catch-up schedules regularly. Is there anyone else besides us trying to check in and provide education for community providers, especially regarding required doses to attend school? Our experience is that they want to give the Tdap only at age 10 to 11 years when they are over age 7 and are very behind on doses. Is there an effective recommended conversation to not offend them in the process? And thank you for being here.
Well, that's a new question. I would hate to assume and speak for them. If I was to make an educated guess, I would worry that that is actually perhaps, I would posit the opinion that that might be more from lack of understanding of the catch-up schedule. And frankly, it does get confusing when to use which product. And so they're busy and they don't want to take a chance or a risk or maybe take the time to figure it out. So, contrary to what we've been saying about facts don't matter, I think my suspicion would be in that case, having very, very easy to understand, graphics for the nurse to just have on the wall in the clinic that just says, yep, at this age do this, at this age do that. So I'd be hopeful that that actually is an opportunity for information rather than communication as the limiting factor there. So that's just my suspicion, but we'd have to have them speak to that directly, I suppose.
Okay, and here's another question. Is it true, though, that some of the vaccines have not been researched extensively to actually determine they don't have any harmful effects in the long run?
Oh goodness, no. I mean, we have a really, really, really robust system in place for monitoring such things at varying levels. And frankly, I mean, for those of you that aren't familiar with sort of vaccine studies, which is a different hat that I wear here at KP, yeah, I mean, just for example, when a new vaccine is being evaluated to attempt to come onto the market, I mean, very typically you are basically matching that against the current practice. And so every time even those studies are occurring, in essence, you're sort of restudying the current vaccine schedule. And so, there's many, many opportunities for sort of continued surveillance and continued work on that at a variety of levels. So again, that's not where the money's at in terms of convincing the average person in my exam room, right? Again, that would be relying on the wrong tools. But in terms of just answering your question in this context, yeah, I think we have hugely robust research that is ongoing to this day on all of our vaccines and our vaccine schedule, as do the other industrialized countries of the world. We're not a lone ship in this. I mean, we are part of a much bigger effort there. So yes, it's not we don't just need to take America's word for it. There's many, many sources of that surveillance.
May makes a great comment, and she said it's helpful when initial mention of vaccines come from the doctor, in parentheses, superior voice, rather than just from the MAs or nurses.
That's that's an interesting one. We different places within Kaiser do things a little bit differently, and I don't believe there's a right or wrong answer to that personally. If you want my opinion, that yes, you can imagine a scenario that's a little more pessimistic. That if done not skillfully, I think that yes, you can kind of poison the well a little bit, so to speak. But I think, for example, in our institution, we actually do have the medical assistants ask. And frankly, knowing that I already have the green light saves me time and energy and is amazing and awesome. Because certainly the majority of people still vaccinate, of course. So, that's a huge time saver. I don't need to like gear up and have a big old conversation if I don't need to. And on the flip side, I think that if you are using that technique, it's just extraordinarily important to make it super clear to the medical assistant or the nurse or whoever is rooming that there is absolutely no expectation. In fact, frankly, there's a discouragement to engaging in that conversation. So for example, the way that we train our staff would be, if the parent is asking questions, for them to just very gracefully pivot to just say, you know, Dr. Hempstead really would be the one to want to answer those questions. I'll let him know that you had some questions about vaccines today, and just very quickly pivot out. So I absolutely agree. We would never want to place a medical assistant in the position of having to somehow adjudicate that discussion. That's definitely a recipe for failure. But I wouldn't be so strict as to say that you cannot have them doing that simple, pre-screening, as it were.
Here's a great comment from May, and I wondered if you wanted to comment on that. I have heard a provider using the wearing seatbelt analogy. He would ask if they wear a seatbelt in any rides, and if so, he would explain the same rationale why we vaccinate.
Yeah, I mean, and to be honest, he might have stolen that from us at some point. That might have filtered through. That's been a real popular one that we have used here for the last dozen years, and I love it. I use it all the time. Actually, it actually works on a number of different levels. It even works on the level of, if a parent came in, when I have a parent say, kind of the what ifs, like, okay, but what if we have a bad outcome from a vaccine and we're that 1 in a million, or what if we get the flu shot and they still get flu? The seat belt and car seat analogy is just beautiful for all those. So basically, like, hey, you use your car seat, it's sitting right there, so obviously you use it. Does that mean that you have an absolute guarantee of no serious injury or death from an automobile accident? No. Okay, but do you use it anyway because it's still the best protection available and it's still worthwhile? You wouldn't think twice about using it. You would be totally nervous to not use it. Yeah, okay, well, that's how the flu shot is. It's not a warranty, but it's still the best protection that we have. And similarly, the other way you can use that, I think, very nice analogy is when they come to you with, well, gosh, I mean, I haven't vaccinated my last couple of kids until they had to have it for kindergarten, and they're fine, right? It's like, well, yes, absolutely. And I go right back to the seatbelt analogy. I say, okay, well, but just pretend that you told me that you haven't had a car accident in your entire life. And so you just are not going to purchase a car seat for your kid. Pause, let that visual sink in. And then they kind of recognize on their own, like, okay, yeah, I wouldn't do that. That sounds a little bit silly. And it's like, well, okay. So, if you had this hypothetical friend that told you that they don't believe in car seats, tell you, hey, I never put my kids in any car seats and they're fine, you'd be able to illustrate for them where the fault in the logic is, right? We can't predict. So again, yes, you've never been in a car accident and you never got in a car accident, your kid was fine. Yes, but that's not how preventative medicine and public health work. And I think it's a really useful way to illustrate those points in a very light, non-confronting way. So yes, the other way we use it is, it's like you drove all the way to LA and then you buckled your car seat. It's like, well, you missed the important period of protection while your child was an infant. Don't buckle it at 4 to get them ready for school. You just took the trip to LA without putting the seatbelt on. So again, lots of ways to use the seatbelt analogy that are fabulous.
All right, Preetha says, can you please recap when it would be appropriate to share evidence that refutes misinformation about vaccines? Which because I know facts kind of don't matter, but when do they matter?
Right. So yeah, let me readdress that part if it wasn't clear. The more vaccine confident the person is, and the more they are asking for information, and the more you just intuit from them that they actually are interested in your answer and aren't just sort of challenging you to a duel or a debate, that's when short, can't be emphasized enough, short answers to questions are something that you want to just, have in your pocket and ready to pull out at any time. So I think a lot of that is intuitive, but that's sort of a way to really specify, here's my opportunity. So someone who really has very fixed beliefs, it's just a waste of your time. So that's the way to hopefully help navigate that.
Okay, and Michelle says, I often use the natural assumption technique, order the vaccine after but then find out parents declined them when the nurse tried to administer the vaccine. I wonder how often this happens and if I'm doing something wrong. Didn't catch how hesitant they initially were.
Right, right. So I'm smiling because it's happened to all of us. So it happens to the best of us, so to speak. So don't beat yourself up too much. With that said, I would argue that if it's happening frequently, then something is missing in your conversation. And again, that can be where, as I mentioned before, there's a real art to the whole natural assumption thing. We really can't emphasize enough. This is not about manipulating. This is definitely not about bullying. It is about providing a clear, confident recommendation. So, not to be judgy, but what that tells me is if you're having that happen frequently, then something is missing in where you're listening or paying attention to their cues, and that you are just sort of declaring this is what's happening without any ability to assess for their level of concern. And that is a growth area and opportunity for you. So it should be pretty rare that that happens. And so the more that that happens, the more feedback there should be, that there should be a little more checking in. Again, any questions at all, any other even if it's just generic at the end of the visit. So anything else on your mind at this point? Have I addressed everything that's on your mind for the visit? Anything else you want to talk about before I go? Right. And you got to watch, you got to pick up on their cues and try to figure out, can you tell that there's a little something brewing there? There's a little reluctance that you see in their face, and hopefully be responsive to that, and just even call it out and say, you know what, I feel like I can tell that you're feeling something over there, but I don't want to be presumptuous. Can you tell me what's kicking around up there? And be willing to do that, and not lean on the tool so much that you in effect are being manipulative. That is absolutely not the goal. So I appreciate the question so that we can really clarify that point.
Okay, we're running out of time and there's still some questions. So we're going to try to get in a couple of more. Priscilla wants to know if you have other resources. She loves the information, and thank you for arguing book. Do you have other recommendations for books about effective communication? She works with seniors and persons with disability trying to navigate through social services.
Yeah, and can you still hear me okay?
Yes.
Okay, sorry. On my end, sorry, my computer just did something weird. I think it's because it thinks the meeting is about to end or something. All right, I'm back. Sorry about that. Hopefully you won't lose me. I apologize if for some reason Zoom decides to quit. There was the bibliography, and so that's really your answer. So just take a screenshot of when you get the recording, or just look at if there's the slide deck there. Either way, yeah, there's the bibliography. So there's lots of good sources there.
Okay, and one more question very quickly. Sarah, I am a special education school nurse and have a handful of parents who refuse vaccines for fear of this being why their child has autism. They receive newborn vaccines but won't follow up with the needed kinder shots, or they won't get any at all. I have always just provided CDC guidelines and offered to be a resource of information for them. Would these students benefit from an individualized care plan in this scenario that states alternative means to protect them, notifying right away if sick, if known outbreaks occur, or any other strategies or resources to help these parents in the school settings?
I mean, that's a tough one, and honestly, we don't have time to really adequately address it. I would just quickly say, I mean, I don't know how much an individualized care plan honestly makes a difference, especially for a school-age kid. I mean, realistically, I don't want to minimize the importance of vaccines, of course, but it's not really an action plan that you would need in a school setting, is my short answer to that. Yes, you would apply all the same things that we've talked about the whole time. And hopefully at some point, if you have a relationship with them, that, ask permission, say, I have some information. I mean, this autism vaccine link has been something we've been talking about for decades now. There's a lot of really important study that is crystal clear that this is not something you need to be concerned about. And it just, pains me to see that this is something that you are concerned about. And I would hate to see, as a parent, you feeling like you could have possibly contributed in any way, shape, or form to your child's condition. And that's really painful for me to think about for you. And I just wonder if at some point you might be open to having a discussion, if for no other reason, just to take your shoulders so that you don't have to feel like something that you did or caused your child to, have this condition. I mean, that's a terrible thing for a parent to have to bear. So I think that would be the way I would try to approach that.
Okay, unfortunately, we're out of time for questions, but move to the next slide, if you will, Charles. I do want to make sure you're all aware of the CIC Summit. They're our co-sponsor for this presentation, the California Immunization Coalition. The link for registration is here, and now it's in your chat. Next slide, please. And always, you're welcome to come to the CDPH immunization updates for providers. They happen every other Friday. The next one is Friday, March 21st. You'll see the registration link for that. It's a great place where all of our, well, lots of our subject matter experts come and answer questions, and we provide updates to you on all the latest and greatest immunization topics. And our final slide, I want to say a big fat thank you to our speaker today, Dr. Ken Hempstead. It was incredible information. Thank you for sharing that. And thank you, Tricia, for sharing all the resources, all behind the scenes support. We appreciate all of you coming and staying this long. It's a little bit longer than we usually go, but you can see now why we did that. Any parting words from you, Dr. Hempstead?
Just again, thank you so much for taking the time and being open to the message. I know that it can be a shift in our approach and thinking, but again, empathy, empathy, empathy. These are great, great people. These are great, great parents. They are absolutely just doing what you and I do every day, is trying to make the best decisions to care for our families. So please lead with that and you'll have great success.
Thanks again to everybody. I hope you enjoyed this. We'll be sending out the presentation. You have the link to the presentation. The recording will be available later. Enjoy the rest of your afternoon. And with that, we will end today's webinar.